Sure. Good morning, everybody. It gives me pleasure to introduce my friend, Dr. Thomas Kretschmer, for our grand rounds today. I have known Thomas through the years, through our Sunderland Society. This is the logo of the society, and this is Sir Sidney Sunderland. It's one of the most prestigious societies for nerve surgery, and you get to know good people. So Thomas is the director of the neurosurgery program in Klinikum Klagenfurt in Austria. And excuse my German, I'm trying to do my best here. If you are like me, you probably don't know where Klagenfurt is, and some of us may not know where Austria is. I know it's in Europe. Thanks to Google Map, you can see here Austria and surrounded by Switzerland, Slovenia, Hungary, Slovakia, Czechia, and Germany up there. If we take a closer look, so it's the blue dot here, that's where the hospital is. It's in the very south of Austria. In a closer look, you can see a lake here on the west side of the clinic, almost like us here, UW Health and Mondota and Menona. But a little different view. So these are some views from the lake. These are just Google views. I'm sure Tom has much nicer pictures from his backyard. But this is some of the views of the area where he works and where he lives. And I just can't wait until you're president of the Sunderland Society so that you host a meeting over there. Thomas did his neurosurgery training in Germany and finished his board certification in 2001, did 3 fellowships, which is very impressive. The first one was Dr. Klein, who trained most of the neurosurgeons doing nerve surgery, but he also did vascular and skull base in Canada as well as Miami. And I don't know if you ever overlapped with Mustafa Baskaya. Was Mustafa chief resident at that time?
No, he already left by that time.
Oh, okay. Okay. And then he can only work as a chairman, apparently. So between 2008 and 2017, he was a head of department in Germany. And then between 2012 and 2017, director of something in German there. I'm not going to embarrass myself pronouncing that. And then in his current location for the past 3 years, since 2017, also director of the Department of Neurosurgery in Klagenfurt. Very well published, and he has written both on nerves and vascular and skull base impressively, and a reviewer to most of the neurosurgery journals. So Thomas, welcome to Madison.
Well, thank you very much for this opportunity to join your grand. Give me a second. Do you see my screen right now?
We do. Yes, thank you.
Okay, perfect. It's a great pleasure, and I feel honored by that. Actually, you see myself blushing. I have no disclosures to make, and maybe we come back to that. You would like to join a meeting in Klagenfurt later on. We can skip that. Maybe one point. We are 2 hours away from the Mediterranean Sea and 2 hours away from Venice, which is a slight advantage, at least in my view. So. What are we going to talk within the next minutes? It's purely surgical, and I want to tell you a little bit about the systematic of extensible approaches for proximal nerve tumors that come very close to the spine. And I think after we finished, you should have an idea why it's beneficial also to sometimes think about a multiportal exploration. On the way, we'll cover on a case base several nerve tumor entities, and we'll talk about surgical objectives. And I hope that by the end of the talk, you're persuaded that multiportal minimization helps for simple and safe resection. Just pointing out to the upper left image, you see the end of the lake. That's where Klagenfurt is actually situated, and the hospital. So just a few more recent impressions. We'll directly dive in. Why do I state that tumor entity decides on surgical objective? It seems clear if we are talking about peripheral nerve sheath tumors, because we usually want to resect them. They are benign. We want to work functional sparing, and so this is clear. This objective might already change if you were talking about a malignant PNST, because sometimes you can't work function sparing, and you certainly cannot talk about cure, but maybe you try to reduce pain. And so we could go through the list. So let's just take metastasis. Usually you cannot change the progression-free survival, but you can change pain. And some of the examples we see here on the list, we'll go over in more detail. Just at the side, excellent paper taking together all Dr. Klein's cases from 2005, and basically gives you an idea if you talk about nerve or nerve associated tumor, what kind of pathology you could mean. So one problem with larger or proximal nerve tumors is that prior to surgery, the entity might be unclear. Plus, those might be extensive, meaning large cases. So what are the prerequisites? So potentially with your surgical approach, you want to follow nerve structure over long stretches in order to develop the tumor from the proximal and distal nerval in or outlet. In the beginning of surgery, sometimes the extent of the actual dissection might be unclear. So the goals might be different. Sometimes you wish for a more confined approach, if sufficient, if it goes more in the direction of biopsy. And sometimes you find out during surgery that you need more exposure, and you want to have the option for stepwise approach extension. And at the same time, you want to minimize morbidity. So it becomes quite clear that there's a need for versatility. And that's why I think sometimes biportal or triportal approaches might be the answer. What do I mean by tumor extension and need for combined approaches? If you look where these tumors can be situated, it might be on a spinal level, it might be on a plexal level, or it might be on a peripheral level, but it might also cover all these levels. If you look on the right, you see just some examples of popular approaches, and every approach might be used for one of these levels. So to me, I think it's logical that at some point of view you might want to combine some of these approaches. If this sounds very theoretically, we'll go over cases right now. We'll start with the brachial plexus in C-spine, and of course we do not only want to have control over nerval structure, but also over the arteries, vertebral artery, subclavian artery, and over bone. So what do you aim at if you work on a potentially malignant tumor of the brachial plexus? As already said, you want to dissect from distal and proximal healthy structure if possible. Sometimes the exposure should not be too large and be limited to biopsy. You want to stimulate for functional testing, and sometimes it might be necessary to go from the plexus to an intraspinal level or all the way to the thorax. Of course, you want to spare function, and points number 6 to number 9 are control points. You want to have control over the arteries and veins, lymph vessels, dural root sleeve, and the lungs apex. Number 10 is a point that sarcoma surgeons sometimes, I think, are more aware of, because with your approach, you want to minimize potential spread. Sometimes, very rarely, I admit, you have to resect also other soft tissue and bone. And one point that, in my view, frequently is forgotten is that sometimes with your approach, you also should enable potential redo surgery. So what do I mean with that table? On the horizontal, you'll find different familiar approaches. On the vertical columns, you find different tumor locations. The cross marks show you what kind of tumor location you can get with what approach. And there's always disadvantages and advantages. If you look at this table, one approach stands out in my view, and I'm not sure if you're familiar with that approach. That's a so-called Fiolle-Delmas approach, and we'll go over several cases and why I think there is an advantage, a definite advantage in using that approach. This is, in principle, this is a T-shaped incision that gives you a very large exposure of the supra and infraclavicular area. It actually was described by Birch in the 90s because he knows a lot of literature. He brought it out of a big book, and then he called it Fiolle-Delmas approach. In my view, it should be called the Birch approach. First example, patient with huge schwannomatosis. Picture on the right shows you that you denude the clavicle and have good control over the tumor just by using a T incision. Next approach. This is a long-time survivor of breast carcinoma. You can appreciate this by a lot of scars all over her body. So this is only a palliative case, and she was in aggravating pain, and there was tumor all over, supraclavicularly, infraclavicularly, and to the thorax. So we planned for a teed incision to give us a lot of exposure, and then we added a subaxillary marking just in case we needed even more approach. And this shows you what massive exposure you get just by using a T. Please look on the right image. You see in white, you see the clavicle. It does not even need to be transected, and you see the whole strand of the vasculature and the plexus. And this is already underneath the pectoralis muscle. This is already the thorax. So after surgery, we only had minor postoperative lymph edema, and I think we could reduce pain quite a bit. Next case, 22-year-old neurofibromatosis patient, MPNST, assumed massive case, tumor extending transforaminally into the spine. So what kind of approach do you use? You want to minimize morbidity. That's I choose a T incision and use the hemi ring retractor system in order to not have to detach muscle. Here you see the details. With the hook retractor, you can lift up the sternocleidomastoid. After you have control by debugging most of the tumor, you can actually, with this approach, very easily control the vertebral artery and go transforaminally into a spinal level. So the FDB approach, I think, gives you extensive dissection with yet minimized tissue morbidity. And I think ring retractor systems are of significant help. You can just adapt the approach. You can make it smaller. You can make it larger. In this case, this was a 10 centimeter large melanoma in a colleague. And the tumor extended to the lungs apex and to the chest, and this is why the infraclavicular part was more prominent. To stress the surgeon even more, this is one member of the neuroanesthesiology team, a young, active male with a 2.5 centimeter tumor at the T1, T2 apex, and he wanted it removed. So in this case, we could choose a very small T incision. And with the retractor system, you lift the sternocleidomastoid, no need to detach it. You see the subclavian artery, you see the lungs apex, and marked with the asterisk, you then can go to the tumor without a lot of added morbidity. Maybe this looks similar, but it's a completely different case. It's a woman and had been diagnosed with a Ewing sarcoma in the plexus. She had radiation. She had been operated at different other departments, yet the tumor was never removed completely and grew, and she had progressive nerval deficit plus very large pain. You see the location is right above vein and artery, behind the sternocleidomastoid, and there's a little satellite impressing the lungs apex. So in this case, you just shift the T a little more medially, and this is shown here. And let me direct your attention to the lower mid picture. This is clavicle, and no need to detach the sternocleidoid. In that case, you directly look on the tumor, and you see also the cosmetic result, as long as you do not torture those skin edges, is quite good. So let us slowly wander lower down the spine. What would be your diagnosis? I think it's pretty clear if you look at this picture. We have a large tumor to the neck, which actually produced a torticollis, which transforaminally extends into a C3, C4 level with a tumor portion compressing from anteriorly on the myelin. So we thought we'd do a biportal approach. First step, resecting the large neck schwannoma, then doing a conventional left hemilaminectomy for the intraspinal portion, and then connecting the corridors under control of the vertebral artery. You can see the patient. We choose a left lateral decubitus position, first transverse incision for the large tumor, and then vertical incision on the back, and this is how we connected the corridors. Post-op picture, tumor removed. Cosmetic result, quite okay. So let's move further down to the chest and the spine, because to the thoracic of the able. If you have a pathology that you would approach
Thomas, we're
via
breaking up a bit.
Pardon me?
We're breaking up a
hear me
bit.
Right now?
Perhaps connect. Now is fine.
It's better.
Just a few lapses there on. It is better now.
Okay, thank you.
Perhaps Wi-Fi strength.
If you had pathology that would extend along the lateral chest, just prepare for a subaxillary incision in case you need it. So in a sterile fashion, you can first place the arm at the side of the chest. If you need subaxillary exposure, just lead the arm. And here's a case where we thought we might use it. You might have heard about a desmoid. It's an extra abdominal fibrohamartoma, which is encasing all the vessels and the plexus, so it's very hard to dissect on it. It's a benign pathology. However, it behaves actually very infiltrative. So it's hard to dissect, and you want to have good exposure. So in this case, there was a large tumor on the apex and on the infraclavicular plexus. We prepared with a T. We did not need a subaxillary extension. However, we had a severe arterial injury during surgery. To date, I don't know from which vessel. However, it was large enough. So we did an instant arterial repair with an interpositional vein graft. And so the message here is whenever cases like this are done, I find it very helpful to have your personal vascular tray always in the room, because the proper clamp at hand saves a lot of time, sweat, and blood. Let's slowly move laterally around the chest. We have here a pathology underneath the scapula, quite sizable, extremely painful. Patient again is in lateral decubitous position. I used the ring retractor system. Here you see the scapular angle, and the arrow shows you how with a hook retractor you could actually lift up the scapula if it were needed. And the whole task is to save, for example, the long thoracic and the thoracodorsal nerve, which you can see here with the full. And Klein popularized the posterior subscapular route, a nice way to approach the plexus from dorsally to an interforaminal level. So he used it for recurrent tumor cases, recurrent TOS cases. The approach-related morbidity is a little higher, because in the original description you transect through the rhomboids and the levator, scapula, and trapezius. So in 2017, Tender and Klein came up with this more focused approach, basically using a C-arm and a spinal retractor system. On Neurosurgical Focus, you can find a very nice video, what it gives you. Let's go to a thoracic level. Frequently forgotten with nerve surgeons is a very old approach that used to be done for POTS disease or tuberculosis of the spine. By removing one or two ribs, you can come very low down, and this enables you to do a whole vertebrectomy. But of course, it's also good for paraspinal tumors that go from para to intraspinal. So, and we're almost, or let's say we are at the lowest etage. We're going to a lumbosacral plexus level and the retroperitoneum. So what might you meet there? The nerve tumors of retroperitoneal space are quite rare. It is even more frequently unclear what kind of diagnosis you have preoperatively. However, the decision on surgical strategy, as pointed out, depends on entity. So the tumor is often within or near the lumbosacral plexus, and the dissection is quite challenging because it's deep, a lot of potential for vascular, large vascular injury, injuring the genitourinary tract, and so on. So even more so, there's an interest in a versatile approach with yet limited morbidity, and the option to expand the approach if necessary, and to develop the pathology from different directions and planes. So some dates about malignant retroperitoneal tumors: poor survival rates, often severe deficits after surgery, 20 to 30% complication rates described, substantial blood loss described, larger series yet older, 4% mortality rate. 1/3, I'm not so sure if that's really the case, but 1/3 thought to be sarcomas. One thing I want to point out, the survival rate does not actually differ if you amputate the limb or if you do a limb preserving approach. So on the first look, might look the same, but completely different entities, completely different goals and approaches. On the left, schwannoma, confined, monocompartmental approach, easy. Here, infiltrative, long spread, bicompartmental approach, non-nerve origin, sarcoma. What kind of approaches are described to the retroperitoneal space? Transperitoneal, retroperitoneal, dorsal, transsacral. Technical devices used are endoscope, a laparoscope. To date, however, only a few reports on approach combinations. There's one by the Mayo Group of Rob Spinner from 2006. So this is a small series of cases from 12 to 16. Let me just draw your attention to the type of surgery. You see a whole lot of variety, from open biopsy, enucleation, complete resection, subtotal functional sparing. If you look on the lower row, you find even if there were benign cases, 100% of them were painful. Half of them had motor or sensory deficits, and 75% of them were non-infiltrative. However, around 60% of them were larger than 5 centimeters. And we all know then if the tumor is larger than 5 centimeters, your potential for malignancy increases. 1/3 of the cases were done with a biportal approach, and there was a fairly even distribution between dorsal, ventral, and lateral approaches. So how do you choose your approach? When I started this kind of surgery, sometimes it was sort of mystical. When should we go transabdominal? When should we go with a flank approach? So, of course, you use your anatomical landmarks. You think about the expected histopathology, surgical risk involved, the envisioned radicality. You need to know about the general condition and take this into account, and of course, the patient wish. If it comes to anatomical landmarks, there's a plethora, and sometimes I don't think that many landmarks don't really help you with the decision how you should go about. And this is why we came up with some sort of simplification. So in green, you see the promontory line, you see the psoas muscle, its medial border; in brown, in red, its lateral border. And you have the infrapiriform foramen for potential extension or the sciatic route. And you have the inguinal ligament for potential extension along the medial thigh. Just a reminder what kind of nerve structure you're meeting. If you're lateral to the psoas, so in yellow, the psoas border, you find the femoral and all the cutaneous nerves. If you lift the psoas, so this is in yellow, the medial border of the psoas, you find the lumbosacral plexus. So if we try to bring this into approaches, we think if the tumor is more superior to the promontory line and more or less on the psoas, we can go with a lateral retroperitoneal approach. If it's below the promontory and it's more in midline, you should go with a transabdominal approach. If if it's lateral and it has an extension, you can combine a lateral retroperitoneal approach with an infrainguinal approach. Then you have extensions to dorsally. So the tumor might extend via the infraperiform foramen. So you would combine a retroperitoneal approach with a subgluteal approach, or it might extend transforaminally into the spine, and then you would do a conventional spinal approach. This is the PR part. If you want to read a little bit on this, I refer you to our more recent paper on that. Let's give you some pictures to this theory. This is how we would approach the sciatic or a tumor in the sciatic route, with a small subgluteal approach, small incision, then get the sciatic nerve and follow the nerve with the endoscope. If there's a need for further dissection, you can go transgluteally. This is this is just one way how you could do a small retroperitoneal approach. You look directly on the psoas and the genitofemoral nerve by using a ring retractor system. Tumor example. So, of course, an F patient, you see the tumor here, tumor outlined with ultrasonography prior to surgery, skin incision, insertion or retractor system. You can nicely develop the lower pole, the upper pole of the tumor, in-leading, out-leading fascicles, and remove the tumor. Example for approach combination from retroperitoneal to medial thigh. Example for approach combination of transabdominal pathology. And in the first step, we had the patient prone and went along with the endoscope to dissect the sciatic nerve. Another example, young student with an F, numerous surgeries before, large, very large tumor from the sacrum to below and above the promontory, 1.5 kg of tumor. So, and a lot of pain, and patient still able to void. So in the first step, we thought what kind of skin incision we might use for the sacral approach, which you see outlined in white. Removed the sacral tumor, turned the patient around and went transabdominal. On the way, removal of another tumor on the leg. So one of the last examples showing you how you can combine pelvic to intraspinal mass. You see in the coronal view infiltrative mass that is here on the axial, directly underneath the psoas muscle, and it's actually growing into to intraspinally. It's always a good idea to check your vasculature too. So with this abdominal athlete, we choose gravitational resection, gravitational retraction, meaning quite an advantage to place patient laterally. You don't even need such a large flank incision. And what it gives you is also the opportunity to go from dorsal for the spinal part. Here you see the flank part. On the next images, you show how you can, it shows how you can flap the psoas, and then you are directly on the tumor, you develop the tumor, and in this case it was actually necessary to reconstruct by sural nerve one of the fascicles. Again, physician colleague with a large tumor that had at another academic hospital years before removal of a benign schwannoma However, now the tumor is bilobar over 5 centimeters and painful, so you don't know, is it malignant or not? It's situated below the promontory, and it's above the inguinal canal and the infraperiform foramen. So that's why we choose, for better control, to go transabdominal. What you see here, we choose to have to go from left to right to have better vision. You open the peritoneum, and there's quite a bit of dissection also around vasculature. In the very beginning, you try to secure the femoral nerve, and then in the end, you actually can close up the retroperitoneum. So the gist for the retroperitoneal tumors, personally, I more or less limit it to these 4 landmarks: psoas muscle, promontory, inguinal ligament, infraperiform foramen, and then I decide on the approach or approach combination. So I hope with that talk I could help your approach planning. I think it's necessary to develop some approach awareness, and hopefully you can see the approaches as modular and as elements that you can combine. So my conclusion is, by the use of natural corridors and cavities and elements of spinal and nerve surgery, together with efficient retraction and endoscopy if helpful, combinations of approaches are sometimes necessary and can help simple and safe resection immensely. Thank you very much. I hope, well, I'm looking on the watch. I think I'm in time. So if I am allowed, I would, am I allowed to draw your attention to our course?
Yes, please, Professor, please do. This is a tour de force, and we all wish to visit your beautiful campus, I'm quite sure. Please do.
I'm confident that at some point of time next year we are allowed to travel again. I'm deeply interested in complication management in neurosurgery, and we tried to put up an international course and conference that had to be postponed. We have a very, very interesting faculty. We will cover everything from nerve, cerebrovascular, skull base, cranial to spine. The big thing about it is that it has another idea in the beginning. On day 1, we talk about performance under acute stress and what we can learn from high performance athletes. We will have a couple of real world-class athletes and a sports psychologist who's talking about clutch performance. And then we go on how you prepare to master complications. I will not go through the whole agenda anymore, but in the mornings, there is hands-on microsuturing, nerve, vascular, spine. And in the afternoon, there's some pretty nice adrenaline-related activity that you can do spread it over the area of Klagenfurt. Thank you very much for your attention.
Thank you, Professor. This is a wonderful presentation, and the lessons you gave are so important for all of us, especially the use of natural corridors. This is important no matter what part of neurosurgery you are practicing. So, and the fact that you combine multiple approaches, vascular, endoscopy, etc. Excellent. Amgad, do you have any comments?
Thanks, Thomas. That was a terrific talk. I actually have a question for you, because we encounter this a lot here. Every now and then we see a neurofibromatosis patient with the entire lumbosacral plexus encased with tumor, and they have leg pain, but intact function. And I'm just usually reluctant to operate on those because you don't want to lose function and almost every single nerve is involved. How do you deal with those?
Very, very difficult question, because I think it's so individualized in these patients. So to me, it's always, I never will decide until I have a whole lot of factors with that. For example, with that one disastrous tumor I showed in that young NF patient, it was clear that we could not prolong her life. But at least we got her 1.5 years, and her wish was to finish her studies, and she did. And we could save voiding. And it's clear, if you would have shown this to a sarcoma surgeon, they would have said this is nonsense, right? Because we never can get something like an R0 resection. And yet I'm persuaded that this was helpful. So I think it's a combination. We're trying to talk very frankly with those patients about the risks. And if you feel confident that you can spare function, I think it's worth to remove the tumor for pain.
Yeah, I almost want to say sarcomas are easier because you don't have to preserve function. Like you're going in and you know you want to save their life, you don't have to preserve function. But the benign ones are the harder ones.
Absolutely true. But I think it's one of the clues can be the exposure. And if you have a proper exposure, I'm not saying it never happens that that function deteriorates, but if you have a proper exposure where you think you can see nerve going in and out, I think that adds a lot to safety.
Sure. Yeah. Any other questions from attendees? Okay, that probably means no questions. I want to thank you very much, Thomas, for joining us today.
Thank you, Thomas.
It was a great experience. Thank you very much.
Thanks again. We look forward to meeting you. Bye now.
Take care.
See you.